Hello, everybody. Good afternoon. After lunch, a very, very warm welcome to this session on lifelong learning for the health workforce. It's a fantastic pleasure to see such an audience, despite the fact that there is stiff competition in the other topics. So it's very good that we're going to talk about lifelong learning in the health workforce. WHO has measured that it can, on average, take up to 10 years before a new guidance or a new technical report get actually transformed into competencies at the level of the frontline health workers. That's a massive gap. And in another way, we expect to run short of 11 million healthcare workers in the future. Nurses and midwives are at the center of this healthcare workforce. I don't think we can deny that. In the latest report, the State of Nursing, issued by our colleagues in WHO, we measure that there are more than 30 million of them. Fantastic workforce, and still. So today we want to do a bit of a deep dive in lifelong learning, meaning learning after people enter the workforce. And while the medical sector and nurses and midwives in specific have actually been pioneers in lifelong learning since such a long time, I think we can certainly say that every country is faced with many questions and challenges on how to implement that in a good way. But on the other side, we cannot deny that these challenges and difficulties are largely different between what we can say wealthier countries and the low and middle income countries on the other side. And even in that very large box of low and middle income countries, the differences are very large also. Now, on the other side, while lifelong learning exists in such a long time, there's such an amount of experience in the health workforce, there are unique opportunities in innovation in many ways. Adult learning science has evolved enormously, and obviously, I guess, for every chair of a panel, it is obligatory to mention the opportunities that we can get from artificial intelligence. So this workshop really wants to explore these challenges with some excellent technical speakers and look at the opportunities that we can see also at global level. But then really, and that is actually the ambition, and we might not get very completely to the end of that ambition, but our ambition, my personal ambition also, is that we could find a beginning to create an alliance or an ecosystem of partners that could actually help at the global level to bridge that gap, that inequity gap between quality and access to lifelong learning in the health workforce at global level, and give a specific attention to the needs of nurses and midwives, and herein also a special spotlight not only on the clinical competencies, but also on leadership competencies or managerial competencies, which we know can make a difference and can save lives. So I'm very privileged, we're all very privileged to have this excellent panel here today, and we will also ensure towards the second half of this session that there is enough space to exchange with the panelists. So let's make it short. From here, it's my privilege to present our first speaker, Dr. Laura Magagna, who is the president and the CEO of the Association of Schools and Programs of Public Health. She represents 150 academic institutes, and she's the founding president of the Global Network for Academic Public Health. Laura, I'll let you open the stage.
Thank you so much. So right here. Oh, okay. Thank you. So good afternoon. It's really an honor to join all of you in this conversation today. And I want to start by framing our discussion, reflecting on the fifth revolution, an era defined by how humans and technology work together, and how this revolution could really be the breakthrough to health equity and the great opportunity to catch up on narrowing the digital gap through innovating lifelong learning to empower the global health workforce around the world. Let's start with how we got here. The first industrial revolution started in 1780 and was based on machines powered by steam and water. About 100 years later, the second revolution was electricity, which allowed mass production through assembly lines. Another 100 years later, around 1970, the third revolution was automation through computers and electronics. And the fourth revolution is where we are now, the digital transformation, automation, AI, connected devices, data analytics, and robotics. And where we are now heading is the fifth revolution, with a focus on humans and machines working together as co-creators. It's about machines collaborating with us to solve problems. This revolution highlights collaboration, ethics, sustainability, inclusion, and well-being as guiding principles. An example is a nurse using AI to assist with diagnostics while maintaining control over care and human interaction. So what does this mean to our institutions, to our academic professions, education, and training? Universities and health professions academic institutions are the architects of the future workforce. If health professionals' education does not evolve, the workforce will lack the skills and values that this era demands. Traditional curricula that emphasize only technical expertise are not enough. Institutions must cultivate digital fluency, which is AI, data science, cyber literacy, human skills, critical thinking, creativity, emotional intelligence, ethical reasoning, and adaptive learning, which is the ability to learn, unlearn, and relearn across a lifetime. The World Economic Forum concluded that the future of work will not be about college degrees, but about job skills updated and at the speed of change. So it's not just about workforce needs updated competencies to cope with the current and future challenges, but job transitions are now the norm. Workers typically experience at least 12 job changes before retirement, and many will continue working into the late 70s. The rapid technological revolution, coupled with increased human longevity, means that education can no longer end at graduation. Gary Matkin coined the concept of the 60-year curriculum, a framework that spans 7 decades of employment and transitions, encompassing continuing education. Health professionals must constantly return to learning, just as the health and well-being of populations continually faces new threats. This is the essence of lifelong learning. We must create on-ramps and off-ramps for lifelong education, seamlessly integrated learning with work. Schools and programs of the health professions must become living systems where education evolves as rapidly as the world around us. With a new approach, an emphasis on learning to live a balanced, healthy, rewarding, and fulfilling life is crucial to preventing mental health issues among our healthcare workforce and preserving a sense of purpose, belonging, and well-being. This involves learning to balance work, learning, and life, as well as developing the ability to cope with stress and adversity throughout life. This is particularly important with all our health professionals who tend to be stressed, overworked, and dealing with other people's challenges. Lifelong learning is not only about what we learn, but also about how we learn. Self-directed learning is crucial in today's dynamic world, ensuring individuals remain agile and prepared for the evolving challenges. The transformation of higher education reflects the need for accessible, skills-based education that is adaptable to various stages of life, with a focus on technical skills, digital proficiency, and increasingly more important, the human competencies. Competency-based education empowers professionals with adaptable skills to navigate complex systems and address population health needs, emphasizing social and critical competencies such as resilience and collaboration. Beyond foundational competencies, integrative competencies are crucial for all health professions. Critical thinking, systems thinking, creativity, emotional intelligence, and teamwork are essential and best developed through experiential, inquiring-based, and interdisciplinary learning. Significant work is needed in our academic institutions to break down the silos in the education of the health professions, starting to train them as the health team we want them to be in the practice. The illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. There are 5 priorities that must fuel the educational transformation of our health professionals worldwide. Number 1, lifelong learning models, the core of our discussion today. Education can no longer stop at graduation. We need flexible, modular, and stackable learning opportunities throughout our careers. 2, interdisciplinary approaches. Challenges of the 5th revolution, like climate change, aging, digital ethics, cannot be solved in silos. Curricula must bridge health, engineering, social science, and policy. 3, as we have said, the human-technology collaboration. Students should not fear AI or robotics, but learn to collaborate with them responsibly. 4, inclusive excellence. The future must be built by all and for all. Equity, diversity, and global perspectives should be embedded in teaching and research. And 5, the well-being and purpose. Preparing graduates not just for jobs, but for meaningful lives that integrate professional growth with societal impact. So beyond preparing students, health academic institutions must also model the transformation themselves. They must become innovation hubs, experimenting with AI-enabled teaching, hybrid classrooms, and climate-smart, sustainable campuses. They must act as bridges between governments, industry, and communities, ensuring that the public good is a compass of technological progress. At this point, I would be remiss if I did not mention the equity consideration. For low and middle-income countries, the 5th revolution has the potential to cause massive catch-up and accomplish big strides if, and only if, health equity is in the middle of this, and transforming access to care and public health only if we have intentionally equity safeguards. Data sovereignty, inclusive training, fair financing, and global solidarity. If not, it can risk widening disparities, both within countries and between the global north and the south. So depending on the decisions we are all making today in the use of AI and intentional equity safeguards. So here are some examples, real examples, of using AI in lifelong learning. Number 1, predictive models. We are already using predictive models in lifelong learning. This can be utilized for lifelong learning, illustrating how this can present an opportunity for massive catch-up. So for example, in Rwanda, they are using it for early dropout prediction in higher education. Machine learning models were used to analyze demographic, academic, and socioeconomic factors in order to predict learning dropouts. They identified the key predictors of dropout, pinpointing at-risk learners, and provided actionable insights for early intervention. So this enabled institutions to offer targeted mentoring and flexible learning pathways, ensuring that learners that present challenges for being remote or for having family or work-related challenges are really not left behind. Number 2, AI-powered skills, forecasting for workers. So it's been tested to design accessible micro-credentialing platforms that enable the workforce to upgrade their skills for ever-changing job requirements from any device at any time. And number 3, adaptive learning platforms that use predictive models to actually personalize learning trajectories. They use personalized curriculum for the workforce and create materials according to every learner. So we are learning every day. And we recognize that the responsible use of AI can provide really access to personalized education and training in remote, rural areas, enabling us to reach healthcare personnel wherever they are. Another example is the Pan American Health Organization, PAHO, which launched a few years ago Paola, which was the world's first digital health worker for alcohol use. So Paola uses AI and natural language processing to deliver personalized, evidence-based counseling on alcohol. It's available in Spanish, English, and Portuguese. Works 24/7. And it's available for free on mobile devices and computers. Paola already reached 1.6 million people in its operations. And it's right now being assessed by PAHO in order to really have an improved Paola for next year. So in conclusion, as we enter the fifth revolution, we need to reimagine what it means to be human in a digital age. So it's not only about smarter machines, but it is about a wiser humanity. Our institutions must rise to the challenge, guiding students and professionals to harness technology while strengthening compassion, equity, and resilience. So by embracing these 5 key transformations, lifelong learning, which is a new social contract that lasts for the rest of your life, interdisciplinary and transdisciplinary approaches, human-tech collaboration, inclusive excellence by design, and health professionals' well-being and purpose, we will move beyond workforce preparation toward really cultivating leaders our world needs, equipped to shape a more just, sustainable, and human-centered future. Thank you.
Thanks a lot, Laura. I think we all agree that is like setting the scene. Very inspiring, essentially optimistic. So let's move then to Olive Tenguera to see the viewpoint really from the Global South. Olive Tenguera is the regional board member of the International Confederation of Midwives, as elected since 2023. She is a midwife, progressing to a doctorate with a focus on antenatal care and currently working as a lecturer and head of the midwifery department of the University of Rwanda.
Good afternoon, good evening. As he said, I'm Olive Tenguera, and I'm here representing ICM, International Confederation of Midwives, as board member for Africa. I'm happy to join you in this forum to discuss about perspective from the Global South on need for continuous professional development to empower the health workforce. A strategic, locally owned, yes, thank you. Locally owned and technology-enabled lifelong learning is essential to empower the health workforce and strengthen resilient health system in the Global South. As said, CPD is essential for sustaining a competent, adaptable, and resilient health workforce and health system in the Global South face workforce shortages, urban-rural disparities, and evolving health burden. So, lifelong learning is both a professional necessity and a health system priority. Even though we have these CPDs, but also we have many challenges to access them in the Global South. Due to limited infrastructure, lack of funding, and connectivity constraints, these hinder CPD participation. And also traditional models often fail to reach rural and remote health workers, as previous presenter was talking about. Sometimes CPD content may be misaligned with the local disease burdens or health system realities. What do we need in the Global South? We need many, but some of them we need these CPDs to be accessible, relevant, and equitable. And also we need local ownership and context-specific curricula that are critical for the sustainability. We have seen there are many programs, trainings for short term, but they are not sustainable for all health workers, and they are not accessed for all from town to remote area. This is needed for local ownership and context specific for our curricula in pre-service as well as in services. Also, we need career-linked incentives that encourage participation. We need to link these CPDs, accredited one, to licensure from professional bodies to motivate, to encourage health professionals to attend and participate in these CPDs. Even though we have challenges and we face many, we have innovative in the Global South. We have digital and mobile apps, and which can work on online and even offline modules. Here we can talk about self-delivery app in partnership with the Maternity Foundation. And this has helped many midwives. It has many modules and in many languages, like 4 or 5 international ones. And it is helping them to improve and refresh their knowledge and even work with the license of their license of practice. Also, branded learning hubs, regional center combining in-person and online learning. We have partners like JPIGO used to have those on-site training, but also has another online hub where people can reach, learn from online and combine with in-person training where they can combine with clinical skills. Micro-credentials, stackable module for long-term career growth, and peer-to-peer mentoring and South collaboration. Here I can give an example. In Tanzania and Japan, they had a model to increase the midwives educators. They started by implementing the master's midwifery and also teach their educators to increase the number of educators as they had shortage of midwives educators. And also we have India-Rwanda collaboration in midwifery education as well and training. Those are South-South collaboration that foster to knowledge exchange and professional support network. That is what I was talking about, self-delivery app. It is like this, and it is downloaded in the App Store and Play Store, and everyone can have it. ICM with the Maternity Foundation have partnered to align this app modules with ICM essential competencies for midwifery practices. And I'm sure it is in many countries in Africa as well as in Asia. And in Africa, midwives are training other midwives because associations are CPD providers. And from the provision of these CPDs, midwives can renew their license from professional bodies and increase the number of membership. Also, midwives can use this app based as a part of their CPD's requirement for their professional bodies. This also promotes the standardized competence-based learning across different low and middle income countries' contexts, as I said, in Rwanda, in Ethiopia, in India, and in Pakistan, everywhere they use this self-delivery app. Also, this helped the Association of Midwives as a CPD provider to enhance the professional authority of midwives, to control the quality and the relevant and tailored content to their profession. And also it helps to generate income. Those who are not active member of the association, when they need this training, they can pay some small fee to generate income for association, or increase the membership. If you don't want to pay, you can also become a member, and you pay that annual fee for members of the association. Yeah, well-designed CPD improve clinical skills, retention, and motivation, and also it enhances patient outcomes and system responsiveness, because we refresh our knowledge and our skills every time, which lead to care, the evidence-based practice. And also it builds resilient health workforces capable of addressing emerging health challenges, and boost professional confidence and self-satisfaction among health workers. Yeah, we need like global alliance, partnership across academia, government, NGOs, and private entity to combine expertise and funding and resources to amplify CPD impact. We have some key policy recommendations. We recommend that national CPD framework, as colleague was talking about, to establish standards emphasizing competence and outcome, not just participation hours. Some countries, they participate, they count hours, and they give credit, but they don't count competencies they gain from those workshops or trainings. We recommend also investment in technology and infrastructure. As we have seen, there is a lack of, unlimited of infrastructure and lack of fundings. We recommend to expand mobile, digital, and offline learning platform for those who don't have internet connectivity in a remote area, to have that offline modules. We recommend sustainable financing, mix governments, employers, donors support to ensure the affordability. We recommend integration with career pathways. We recommend that link CPD to licensure, promotion, and remuneration to be recognized as someone who has taken these CPDs. We recommend also the scale-up or decentralized, localized models. Use those regional hubs and the mentorship network to reach even those rural health workers. Also, we recommend South-South collaboration, because we share context, similar settings, to encourage these low and middle income countries to share CPD's innovations that can work in their context and share best practices. Lastly, we recommend global alliance in CPDs by reinforcing the global collaboration to scale up high quality CPD content for a robust health workforce. Thank you very much. That is what I have to share.
Thank you very much, Olive. Clearly presenting a strong illustration of the gaps we've mentioned, but also bringing examples from innovation that come from the South, solutions already identified for problems, but also that same call for an alliance that can reduce this gap in inequity. From now on, we'll move more into a conversational part of this exercise. So now it is my pleasure to present two more members of our panel. So two senior leaders of top-class medical institutions here in Europe. Firstly, Professor Dr. Heo Krummer. He did not have to travel far as the CEO of Charité University in Berlin. And secondly, from Denmark, Professor Rasmus Møgelsvong, the CEO from Rigshospitalet in Denmark, a medical specialist in cardiology and professor in cardiology. So I've prepared a couple of questions from which we will start the next part of this conversation. First, for both of you, how do you see the future of lifelong learning for nurses and midwives? Where are the future challenges, and including around managerial competencies and leadership? And what opportunities and solutions do we see? So, who wants to start?
Well, if it's okay, I would start. Thank you for the question. I would like to start with a general remark, and I'm really happy that we have such an audience for such an important question, because you could ask, what is currently different? We had lifelong learning in medicine, in nursery, forever. I mean, everybody who was in these professions had to learn throughout his or her life. Although we think that we are at a kind of a turning point, and I would like to try to define why that is the case. If you think about lifelong learning, on one hand, it consists of content on one side and the learning technology on the other side. And I think both sides are under rapid change currently, because the content, as we heard impressively from you both, changes more rapidly than in the past. And I think, and I would really take off on that, the learning technology changes in a way we have not you could not project that a couple of years ago. And I would, to put that short, I would like to combine it with a rather optimistic thing, because the rapid change in the learning technology, I think, is one opportunity to really reduce the gap among countries. Because if you think what happens in the next years, today we have a situation, or in the past we had a situation, that learning had a very personal aspect. You were sitting in front of somebody who teaches you. If you think about that, this goes away. At first you think it gets less personal, everything is digital. But if you think beyond the depersonalization in digitalization, and you come back to the AI issue, it's quite comparable. It's conceivable that in the long run, the AI technology will help to really personalize education. I mean, if you think on the long run, you have an avatar sitting on this table, and this one will talk to me in a way like a teacher did it in previous times. And it's an individual teacher to me who's able to see my capacity and adapt the individual learning to the capacity. You don't need any buildings for that anymore. You need some IT technology, which is ubiquitous nowadays. And you can have an association, or you can have an individual adaptation to your individual capabilities. So in the long run, what happens here is a real revolution, and we have to think about that. So I wanted to make this short remark in the beginning. Otherwise, going back, of course, to your question, the continuous professional development, I think, for each of us, has become a real cornerstone of professional excellence in healthcare. I mean, each of you in the room has to maintain and expand their competencies throughout the lifetime of their careers. We at the Charité Medical Center in Berlin, we think that the CPD is really a strategic enabler of professional identity, of quality improvement, and of interprofessional collaboration. We did not touch that really now. I think that will be an absolute cornerstone of future development, that the professions work much closer together. We have a hybrid CPD program for midwives, which engages freelance practitioners, emphasizes communication and really reflective competencies. And we think that this approach aligns with international best practices. And as I tried to say, that if you look at it globally, the healthcare is really being reshaped by the digital innovation, by demographic change. Just one sidestep. The Federal Republic of Germany will lose 30% of its workforce. And this is also true for midwives and for nurses, 30% during the next 10 years. So within 10 years, we will lose 1/3 of our workforce, and we have no chance to replace them because the following generations are simply not there. So it's a huge, huge challenge coming from these things, which I think have really accelerated a move toward hybrid, flexible learning formats. And I said that we face the kind of unique challenges in this system. It has in some parts to do with the traditionality of the German healthcare system, which is still pretty much physician-centered. And we are in the process to improve interprofessional collaboration, try to evolve that. And for that, the nursing education was introduced in my country. The academic nursing education was introduced quite lately. So we are still behind that. But with the future, which I try to sort out, we are quite optimistic to change that. And if you go now to Denmark, so we look across Europe and globally, I think we'll run into a persistent shortage of workforce. I think it's everywhere the same. It has not only to do with demography, it has something to do with keeping the jobs attractive, interesting, highly professional. We need to work on that. Currently, we have high workloads, staff attrition, burnout limit opportunities, they all limit the opportunities for the professional development, so we have to learn on that. If we address these structural problems and combine them with the things which I initially started on, which are these enormous technical developments, I think we can both make the jobs attractive. And on the other hand, I'm pretty sure, and I guess we discussed that in detail because you are the two experts on that, I think it's a real opportunity to kind of reduce or close the gaps which we currently see between parts of our world. That would be it. Thank you that you listened.
Thank you very much. First of all, I will say thank you very much for the opportunity to be here, and also thank you very much for two brilliant presentations. I do agree much with all what has been said, also with Hayo, that we have to look at learning from a different perspective. We don't see it as a standalone activity. We actually look at it as a strategic driver for transformation. So two reasons for that. We have been touched the topic quite, not briefly, actually very well elaborated over the thing that evolution is happening very fast, very rapid. So when we look into the doubling time of medical information, the amount of scientific publications, in the 50s, it took 50 years to double the amount of medical publications. Today, it's less than 3 months. So the enormous vast amount of information is something we need to deal with. And one of the things is naturally AI. I won't go into that right now. We have touched upon it. But the other thing is that the general transformation needs different ways of look on how we engage our organization. So what we look into is that we have reimagined learning, looking into it should be a more integrative and empowering process where staff actually takes control and responsibility for their own learning. So what we try to do is actually make the frames as leaders for our healthcare staff to sit together across disciplines and discuss and open the perspectives about not only clinical excellence and how they should do the work, but also about well-being and how to collaborate. And we have quite a few examples now where we have succeeded actually empowering nurses and doctors sitting together, not only talking about the clinical part, but actually talking about well-being. And we can see that they now succeed in making the schedule planning, where they can actually have the liberty of how they plan their work together. They can also plan their resources. And when the topic is specific midwives, we actually had an issue where all the young midwives who started just after school were very frustrated about the responsibility they faced sitting with women giving birth. And the senior midwife was actually having difficulties feeling the responsibility to be assisting all the young midwives. So naturally, the solution didn't came from the corner office at the director board. It was the midwives themselves sitting together with the nurses and the doctors, talking about how could they actually solve this situation. And what they found out was a mentoring program. It doesn't sound highly brilliant, maybe seen many other places, but the thing is they discovered it themselves what they want to do about it. And what they did was a mentoring program where one senior midwife had the mentorship of 2 to 3 midwives. They planned the schedule so they were all always on work together. And what was differently was instead of the young midwives being escorted by a senior for the first month, they actually started out from the first day sitting alone, the young ones, with a woman giving birth, knowing that the mentor was just next to them. And the mentor knew that they only had the responsibility for 1 or 2 of the young midwives, making their stress threshold much lower. It seems simple. It is not the solution that is important. It is actually the process about how do we empower people to see the solutions, do the possibilities, take ownership, so we can actually accelerate the transformation. I could say much more about AI, but I think we'll touch upon that topic again later on.
Okay, great. So let's move then to this gap and this global alliance. How do you see this? Can we create this? What kind of an alliance can be created to ensure that the lower middle countries are not left behind in this enormously rapidly moving field? And do you see a role for your institutions?
Definitely. Can I start again? Of course, we see a role for our institutions in that. And I would like to talk a bit about the importance of global collaboration to what we touched a bit upon, reducing the gap. And I think it's pretty clear that the global inequality in healthcare is really perpetuated by unequal access to resources currently. And the resource defined, as I tried to say in the first answering, getting a bit fresh here. And the access to resources may really drastically change if you look at it in a longitudinal way, talking about the ability to do other things than really personal interactions. We think that the international collaboration is really essential to close the gaps, and we ensure that we try to contribute from Charité that all health workers, regardless of geography, can really access high-quality professional development opportunities. And we at the Berlin Medical Center really recognize that an equitable collaboration really has to move beyond one-way knowledge transfer, which again, the two-way knowledge transfer will be enabled by technical capabilities. Instead, a partnership between institutions, between different type countries, should be structured around the mutual learning, the co-creation, and shared accountability. And I think that examples of a really meaningful collaboration with the aim to reduce these gaps include joint capacity building initiatives. One should co-design curricula which are tailored, of course, to local context. But on the other hand, if you know the local context of the other one, you learn a lot by that. And I think collaborative research is necessary to strengthen local evidence bases. The partnerships also must address ethical dimensions. And I want to talk to one aspect which really touches my institution. We had a massive shortage of nursing, in particular following COVID. And the answer of the institution was to recruit well-trained nurses from other countries, which was an absolute necessity to keep our institution going. On the other hand, raises high ethical questions because these particular well-trained people lack then in their home countries, and how to deal with that. Whether you at the end of the day may take an advantage having people being exposed to an international different environment for some years and then returning to their countries is a completely different issue as having them permanent with us. And I think this is something which has not really been systematically explored, both in terms of the consequences of the practical issues. On the other hand, there are countries which have which kind of train more nurses than they individually need. And then I think it's acceptable to go that way. But I think that's an important thing we might discuss under us. I mean, otherwise we could exacerbate global workforce imbalances. And I think a sustainable capacity building must be the guiding principle for future collaboration. Thanks.
Yeah,
And I might just continue on that note, the lack of resources, how do we avoid brain drain? And I might say we go in it in two directions. So one of the direction is actually to identify what do we use our resources on in the global north. So we believe that there's a huge potential to actually stopping some of the things we're doing, so a lot of the procedures we're doing. We actually think that we contribute to a lot of waste, and that affects the climate, and that is the most major factor for global health in the census. So we actually believe that we can reduce 1/3 of what we're doing, realizing that, as you said, I was a professor when I was that and not into admin. I thought we were very evidence-based. But I've realized that we only have evidence for 10% of what we're doing. 90% is without evidence. Doesn't necessarily mean that we need evidence for all what we're doing. I mean, if a person is bleeding, it is probably a good idea to stop the bleeding. You don't need a large study for that. But still, 90% of what we're doing, we don't know if we're actually providing any value for the patients. So we want to scale that up. So we are performing something called platform trials, where we have made it easy to perform a series of randomized clinical trial of all the things we're doing, all the low things where we just started it 60 years ago, and then we just added another pill, another examination, another something on top of it. So that is one of the things, building platform trials, and we do it in collaboration with the other Nordic countries in what we call the Nordic University Hospital Alliance, because we also need speed to find out what should we stop doing, using our resources to. So that is one way of identifying low-value care, so we can use the resources into high-value care. The other thing is it also provides a network of working together across sectors, across borders. And that is a thing where we can actually start sharing knowledge, sharing not only clinical excellence, but actually also organizational thoughts and how we organize and decide what we're doing in each organization. And we hope that this framework would actually be growing steadily. We start with the Nordic countries because we are very alike. It's easier. Nothing is easy, but it's easier to do that with all the legislation and the collaboration that is already existing. But we generally hope that we would adding hospitals after to this framework network where we can share knowledge, share and also implementation. I mean, if we find out that something is really good, then we could also implement that way. So that is some of the thoughts where we think that we could easily contribute.
That is great. Let's move immediately to the next point, and it's my pleasure to introduce our last panel member, Amelia Tupulupu, who is. I'm very happy. First, now let me present myself. I'm the director of learning for the WHO Academy, and welcoming Amelia, who is now the Chief Nursing Officer of WHO, and in our restructuring of the organization, one of the pleasurable effects of it is that Amelia's office is joining the WHO Academy. She was formerly she was actually the first female Minister of Health of the Kingdom of Tonga, and was there also the country's Chief Nursing Officer. So, Amelia, can you give us an idea from the WHO? I mean, we said it already, 30 million of them, nurses and midwives, by far the largest group. What are, in your view, the priority needs in learning and lifelong learning?
Thank you very much, Bart, and it is such an honor to be here. There are, of course, many priorities and needs, but let me speak to about 3 of them. First, before quality education, let me speak to fair working conditions and creation of jobs with conditions led by the member states with local leadership for long-term and sustainability. Of course, quality education is one of the key pillars with the global strategic directions for nursing and midwifery. And of course, competency-based education, meeting quality standards, meeting accreditation standards, meeting health systems needs, and also, most importantly, population needs. And of course, within it, as I have heard from everybody, competency, skills, clinical skills, continuous professional development as a key hallmark for patient safety, patient satisfaction, and building a competent, motivated, and compassionate health workforce towards the future. So, and of course, with emerging situations right now, incorporating to the curriculum climate change and also settings of fragile, conflict, and vulnerable settings are very important for special considerations within the competency-based education moving forward. One of the key pillars within education is leadership, and Bart have spoken to that, and our panelists, and that is a very important area for building, one of which future leaders and managers to lead frontline care for the population to ensure safe and quality care is delivered all the time for the population. But of course, also maybe some consideration around a professional, multidisciplinary, a holistic approach to leadership management for the health workforce. Maybe in some of the countries where it is moving favorably and with local leadership, the advanced practice nursing agenda may be a way forward within those contexts where it is already moving on the ground around there. I think, Bart, I'll give it back to you now, as I know the time is running out. Yeah, thank you very much.
Thanks, Amelia. And well, first maybe, I don't know, Rasmus or Heyo, on the specific point of leadership skills and competencies, do you have anything specifically what you see is new? Because we all know that you mentioned organization of healthcare services is enormous, but that first line supervision, there, of course, competencies shift also. Is there anything new on that front that you could?
I think we touch upon many things. I would take up something that Rasmus talked about, which is kind of the velocity of development. So what I think is that we have more frequently kind of control what happens and adapt to new developments. And the other thing with the competency issue, I'm really fond of or a fan of real co-education. To have in part the different contributors to medical success, to treating people, which is an entire team nowadays, which will in the future consist of maybe also other experts like people who know AI or IT. If you really want to form them as a team, you have at some point in time really co-educate them. So they have to sit together in a university and learn things. We have some problems with that in Germany on the legal side, but on the long run, I'm totally convinced that this will lead to real teams where you can shift the competencies kind of without major borders in education. So that would be one point I would really like to emphasize.
And I might add that I think we're moving in the Nordic countries away from command and control leadership and more into empowerment and actually facilitating that our staff is taking responsibility beyond the organization. So we had a new vision calling that we should be of benefit for the individual patient and the general healthcare system. And that means that suddenly prevention is something that our staff is looking into, because we actually need to prevent the diseases we are using our resources to treat and that our patient is suffering from. And that is a different perspective. So we also see that they move much more into when we talked about how, when we have workforce shortage, that is a global problem, how do we avoid brain drain, is actually, instead of you looking at as we normally do, moving people around and saying then that they consist of skill. How do we work in networks where we actually put the different competencies into game? So one of the things we do is that we try now to do remote diagnostics. So the most advanced MRI scan we can now perform very far away from the hospital. Like Greenland, that is 3,600 kilometers away from Copenhagen, and the people who are doing the scan is sitting in Copenhagen, and the personnel that is actually around the patient is trained in the safety, but not in how to perform the examination. And then that means that we today can do the scan, but also mean we have made a network, a platform for continuous training, because we can do that on the distance. It actually goes so far that it's not only the diagnostics we do on the Faroe Island, Greenland, Bornholm, and many other places, but now we actually move into brain surgery. So we actually had the general surgeons from Greenland at Riks in Copenhagen trained for a short period, going back again. So when they now receive patients which need emergent brain surgery, they start the operation, the neurosurgeon in Copenhagen, as more than 3,000 kilometers away, sit on a screen, drawing on the VR glasses for the surgeon, close to the patient. You should cut here, put the pion there, do this and do that. And they actually succeeded doing that. So we think that finding the solution is not something for leadership, it's actually for our staff who's close to the task, close to the patients, know the demands, and they actually should have the autonomy to think what they should do, use their resources for. They also, by talking between sectors, between hierarchy, they belong to a group and they find meaningful contribution into doing these things. And that is going to accelerate the way we transform healthcare.
Can I maybe add one point to what Rasmus said? The issue of distance to the hospital, to the original hospital. I think in times of demographic change, we will have more and more the obligation to transfer procedures away from the hospital. And the entire idea of hospital at home will be something which really challenges everybody in nursing. And if you look to countries who do that successfully, it's in the meantime unbelievable what they can do at home, both in taking care of pregnant women, of high-risk pregnant women, quite far away from a hospital, being on a digitalized supervision. But then the I mean, the responsibility of the individual person, for example, nursing person being at this home, increases a lot. So I think the entire issue of hospital at home, to really think that through from the nursing side is an important thing, just as you said for Denmark, there were distances between the original hospital and the peripheral parts.
And then, of course, if we think like that, at distance, then we can also think how we can create one of these essential functions of high-quality lifelong learning in nursing care, that is clinical mentorship. Sometimes you cannot find the best level clinical mentor next to that nurse that is essential. Why not imagine that we can have quality at distance? But now let's really move into that part of how we're going to, can we build this alliance, this ecosystem? Amelia, what can WHO do to facilitate or create this alliance or ecosystem?
Thank you very much. It is such a pleasure to be here with many partners in the house. So WHO can be a catalyst and hopefully convene network and partners with all of you to work together. I think that is very important and critical for the future.
Excellent. So maybe a short round with the whole panel, and then we move into the audience. Okay, what are elements that can contribute? We heard a lot of interesting ideas. So how to bring these elements together? How to see that gap can be closed while everything is moving so fast, which is normally impossible. But let's see how things are possible.
Yeah.
Laura.
Can I start by just reacting a little bit? And thank you so much for your presentations. And you made me think a lot that we are expecting for our team to work in teams and to be really relying on one another. And then with my hat of the, representing academic health professionals, I just can't help but to think that our system, our educational system, is not yet there. We are so traditional. I mean, think about any university. I'm just thinking about even this room right now. This is a school-based room. 100 years ago, it was exactly the same. 100 years ago, it was exactly the same, right? And if you think about the telephone or any other industry, in the last year has changed dramatically. But education, it takes 1 century, and we're still, having problems with the physical class. So I keep on thinking about what will be, and that's an excellent, I think, that conversation to have among all the academic people around here in the room and beyond the room, in terms of what are the innovative ways of learning that the practice is showing us, which is a team and then remote. But how do we teach that? And if you go to the universities, we are so silos. The nurses are here, the physicians are here, public health are here. We don't even talk each other. And we know that we need to be working together and even beyond, as you were saying, not just in the health professionals, but with the engineers, with the economists, and with the architects and beyond that. So what do we need? How can we learn from the whole world, the experiences that everybody has? And that's why I think that a space to collaborate, a hub, where we can bring case studies from around the world and best practices in how do we, we need to push innovating education and training for all these competencies that we're just saying, and the team that I just don't see the universities there yet. And you were talking about the other thing about the mindset, and I think that's exactly where we need to start. We need a different mindset that, now education and training should be just different, and how do we get there? And the last point I want to say is just that the co-creation, too, that somebody also said, I think that's extremely important. How do we, bridge the gap between, the world around is co-creating. The same thing that I was talking in my presentation about co-creating with the technology. Well, it's also co-creating with people around the world, because everyone has something to bring to the table, and we need to co-create in that regard. So those are my
Good. Olive?
Yes, thank you very much. To move forward from vision to action, I can say that every country, every partner, stakeholders like us, every regulator has a role to ensure that nurses and midwives, as backbone of the primary health care, have opportunity of lifelong learning and also lead. I can say that we have many CPDs which are related to clinical skills, not managerial and leadership skills, but are needed for these nurses and midwives. I think we need to institutionalize within Ministry of Health and the healthcare system those CPDs in managerial skills, in leadership skills, from bottom to upward. If I can say, from south, there are many need of having those nurses and midwives in those desks at ministerial level. This is needed to have embedded competence CPD in those areas. Another thing is like commitment of government to ensure that CPD are accessible to nurses and midwives, as well as collaborate with WHO, ICN, ICM to help nurses and midwives to reach even to those remote areas to the CPD. That's what I can say. Thank you.
Great. Further down the line, any?
I think it's very interesting what you said, Laura, upon, I mean, we cannot shape the future of global health using yesterday's methods. And it is quite interesting we're sitting here doing like we normally do. And I think that is actually also a point that this Wednesday we held a EU presidency conference with 320 people from the entire ecosystem. Brilliant minds who know a lot about what should we actually do when we look into this. There was patient organization, there was ministers, politicians, big philanthropic funds, industry, university hospitals. So we try to do what we do in daily clinical practice, and we quite bold move with these 320 persons. We actually asked them to roll up their sleeves, and we made roundtables, 40 of them, sitting in groups of 8, sitting together, sharing perspective, because we were actually the entire ecosystem that need to engage into dialogue, sharing perspective, and actually find the solutions. And I think we need to do things differently. We need a paradigm shift in the ways that we actually are looking on transformation and using our resources. So just adding to Laura's perspective about that, we tend to do things the way we have learned to do them, and we continue doing it. But if we want to do things differently, we have to do it differently, and we have to use new methods. And especially we tend to forget the young ones. I used to be one, but not anymore. So we forget that they don't have all the restrictions we have. They are much more into thinking bold solutions, and we need to have them sitting at the table together with the rest of the ecosystem, because they're the good ideas come from.
Before we...
Well, maybe one comment. It was pretty clear from several contributions that basic things need to change. On the other hand, we all know how long it takes. So what are we doing today and tomorrow? And I think there are options we have, like further developing the scalable hybrid CPD models. When you combine the in-person excellence with the digital issues, you could maybe get in shorter time real progress. And I'm really still fond of hosting something like international platforms for exchange, like we do it here now. At Charité, we have an upcoming normal labor and birth research conference in Berlin in September 26. And there happens exactly that you have on the one hand the personal interaction, on the other hand you take all the advantages of digital improvements, and maybe we can also define between the bold things to do the small steps which really kind of lead to progress within a definite amount of time.
Great. I think it's time to hand it to the audience. So we have time for a couple of questions, comments, remarks. I don't know where the microphones are. Yes. Well, let's not go to the first row. Over there.
Yeah, excellent panel. I had really enjoyed it. A lot of points. I'm from Apollo Hospitals in India. One thing I did not hear about is reskilling or adjusting skills. Why should only a doctor or a nurse do what is being done? It's a very fundamental question. If you look at Indonesia, the Minister of Health there said, mothers are treating coughs, colds, diarrhea. I'm going to teach them how to treat diabetes and hypertension. You immediately got 1 million+ trainers. Why can't we think more fundamentally? Most of us take care of our colds and coughs. We don't go to the doctor. Half the times things are placebos. So do we need to think more fundamentally about health?
Anybody wants to answer this question?
I would like to start. That was actually one of the suggestions when last Wednesday that 80% of what we're doing in hospitals should be at home, and empowering patients and relatives to do that. And I agree completely. We have to look at all the resources we have, and there's a lot of resources there. Naturally, that is not for all, but then we can use the resources of ones who are not that lucky to have relatives or a mom or a father who can do it. We actually try to work with that, and only imagination set the boundaries for that. So right now, we are actually training all our patients to provide chemotherapy for themselves at home. So normally, when we look at all the hematological cancers, they were admitted for 4 weeks, and then 1 week at home, 2 weeks at home, and then again 4 weeks. That's changed completely now. So the patients are trained, and they have 2 admissions during a long course. It might be 2 days up to 7 days, and 75% of them is actually compliant with it. And then we have a help desk where they phone and say there's some arrow saying F25, and then it's just air in the catheter or something, and it actually works. And we also now do it for kids, even very small kids with leukemia, and the parents do it. So actually, people have much more skills that we actually are using. And back to the gray hair, I think we need help to imagine what we actually can do.
Thanks. I would actually like to attract some questions on contributions towards this alliance or ecosystem to limit the gap. Who wants to offer a question like that? There and then there.
Thank you very much, the panel. My name is Didi Nadiri, and I work for Charité as a nurse. And my question is regarding the conflict, or rather the differences between 2 generations of nurses who have different perspectives of artificial intelligence and use of digital infrastructure. How are we able to connect the 2 generations so that they can also understand each other without causing a fight?
Yeah, between the old-fashioned and the new-minded.
Well, that's exactly what we mean by changing them. Start with changing the mindset, right? And starting really in education in the universities. We need to start training. I mean, but let's face it, our daily life. Where are you? Okay. Our daily life is about digital education. The way we consume information right now, we want it or not want it, is through digital means, right? So we think that the community, we think that the other, but that's, I mean, my mom has 94 years old, and she actually, she sent me messages through WhatsApp, right? That's how they, I mean, we don't realize how much they are really relying right now in technology and digital. So I think that is just a way of just being aware where people are. We need to meet them where they are, but we need to bring them to the, and sometimes it's is really more on us than on them in terms of like what are the new things that we can really provide the environment in order for everyone to learn, at their own time, at their own pace, wherever they are.
Gentleman here. Here, the first one.
Hi, my name is Shahid Yusuf. I represent a company based in Vancouver, Canada, but work significantly in Asia. Excellent panel, excellent learning. One of the things that you talked about was not just the curriculums, but the CPDs and how it will actually change. My point here is that things have changed. I mean, the bus has already left. And some of the tools which have come out already, I mean, I know of a company who has developed an IT tool based on AI, which can predict if the pregnancy can go wrong at any given time. It took them 5 years to do that, and it's there, but now this training of a midwife can be totally changed because it's something new, it's out there, and we can actually use that rather than the typical training that we actually do. So my point here is that it's not just that the North and South collaboration, the South-South collaboration, and from South to North collaboration needs to be speeded up. I was in a panel discussion earlier, and we heard a talk about how telehealth was brought into to Germany. It actually started in Africa. So, I mean, I'm just simply saying that first we need to sort of map out what are those innovations which is out there. How do we actually take that, and how do we just turn around the complete curriculum, because it actually needs to be turned around completely now. It's no longer the same curriculum anymore. Thank you.
Thank you for this remark. At the back. The lady at the back.
Hello, I'm Yashasvi, and I'm from India. And I'm a medical student representing IFMSA, which is International Federation of Medical Students Association. And it represents around 3.5 million medical students worldwide. So my question is that when I hear health workforce, my mind directly goes to the rural health workforce. And what I see is that in countries where our resources are limited, we have to be careful whom to prioritize and how to prioritize. So, like in India, there is an initiative called Ayushman Bharat, where we digitalize the patient details. But in my place, which is rural, I don't see it happening because there is lack of competency, there is lack of technology, and the doctors do not have enough time to take out to learn those skills. So how do we make sure that the medical professionals in rural areas don't miss out on the new medical guidelines and the new innovative models that we are talking about? And one more smaller part of the question is that since I'm a medical intern, how do I make sure that I stay competent when I come out of my college? And also, it doesn't take, since I'm an intern, I can't take out too much time out of the hospital. So how do I make sure that these training models are included in my daily life, like training? Thank you.
Anybody wants to? We have time for 2 more questions.
No, we have to answer that. Huh?
It was a question.
It was a question. We have to answer her. Or?
But I checked whether there was anybody.
Oh, no.
We tried, yeah, we can do it together. I mean, it's pretty clear. We are a large educational unit, and the thing which you kind of mentioned or argued is pretty clear, that in the future, in your daily life, this way of getting new knowledge will be much more integrated into your daily work. I guess there will be a day per week where you just have what Rasmus said, the increase in knowledge, as far as that is still in your brain and not in your phone. It will be something really important to integrate that into daily life. We don't do that currently because there's a complete overload of work and people don't have time really to adjust to the current knowledge. But we have to find ways to really do that, because otherwise it will be impossible. The rural issue and how to get healthcare really to rural parts and keep that up to date is really it's a pivotal question. And the only way I would see you can do that and keep it on a contemporary mode is that you use digital technologies. And I think it's from my point of view, it's the only way to really get that done. And that, on the other hand, to really guarantee the transfer of knowledge by digitalization, that should be possible even in rural areas, I think.
Can I just add, first of all, thank you for being here. We need you. We need students and we need people, really young people to be with us, helping us co-creating exactly the future. So thank you for being here. The secondly, I just want to echo, remember, we need a new social contract from the universities. The social contract means that you're not just there for 4 years, 6 years to get your degree. You're going to be there all your life. 60 years curriculum, right? Because that's exactly the kind of things that we want, that while you work, you are learning. So learning is going to be part of your schedule. And I know it's overwhelming already, but it has to be part of our everyday work, the learning part. Thank you.
Okay. I have one question over there.
Thank you. Hello, my name is Jenna Diallo, and I am a global health researcher and a monitoring evaluation specialist that focuses on workforce development in the States. I did have a question that had to relate to funding. So we do know during these times there's a lack of funding. Funding is getting tighter from federal sectors all the way down to nonprofit organizations. My question really is focusing on how do we ensure that CPD does not lose the depth and the quality that exists while also advancing and sustaining impactful solutions in the public health workspace or global health workspace.
How to fund all this? How to fund all these brilliant ideas? Who wants to?
That's a complex question. But the good thing about it is necessary that we find a solution. And echoing the questions before, we cannot keep up with the way we do today. So there would be a market for industry also to look into how they do it, but there would definitely also be philanthropic funds that are very interested in seeing how we do these frameworks, these networks. And just to add, when we talk about AI, naturally no one can grasp what the information that is spit out everywhere from to actually be updated. A Danish medical student today who is finished is only 5% updated. That's a problem. So what we do is that we already had AI algorithms that support the GPs, but it takes too long time to validate them and to see that they are 100% sure. So the young doctors now, they use ChatGPT and everything. So when they have a patient in the ER room, they use it. And they look at the blood sample, and I had a story yesterday where there was a young patient coming with headache and nausea, and naturally they thought meningitis or subarachnoidal hemorrhage. But the blood sample, ChatGPT suggested carbon monoxide poisoning, intoxication, and that was the case. So we cannot keep up with the demands, so to say. So I'm sure there would be funds and interest in developing that market because it is coming.
And we should keep in mind, I think it's really an important question, that there will be special types of patients who require special attention, which will never be really funded by general funding. I spent my last night on a night with patients with amyotrophic lateral sclerosis, and there were nurses reporting how to treat these particular patients. And this is something complete out of the regular business of insurances and things like that. So what you asked for was, I think it's really a pivotal question. There are parts of it which need to be funded by other activities like philanthropy or like private things. So it's really, you have to keep in mind that there are subsets of patients which are kind of not really supported by the general systems. And that's a major task of nursing.
Mm. Yeah. The last question, the lady, the pink, yeah, exactly.
Thank you very much. My name is Brigitte Bürlen. I made a foundation, the We Foundation for Family Carers. So my question is, we talk what we think they should do. Shouldn't we think about what we together can do? For when it was said that hospitals are too expensive, yes. We should do it at home, the caring work. But who does it at home? Professionals, I don't think they can manage it 24 hours round the clock. So who is the people who should do it? And I think it also that we have to build interfaces between science, economy, politics, society. We really, and also our environment. So I think we should, or I ask a question, shouldn't we sit really all together, also across the borders, and think about how we all together can manage it, and nothing about us without us? Thank you.
Yes.
So, healthcare delivery as a whole of society aspect. Anybody wants to comment further?
Completely agree. That was.
Yeah,
I actually tried to say it earlier on, but it wasn't clear. Apparently, that is exactly what we're going to do. We need to sit and have the dialogues and share the perspective, and actually be curious about other perspective, because there might be something into it that we haven't seen ourselves. So definitely, I agree 100%.
And it's a kind of the issue of health in all policies. It's pretty clear that in medicine we will run into problems within due course. If you think about gene therapy and other things, we will run into problems which you cannot solve inside medicine. So it's an absolute request to integrate all parts of the society in these pivotal discussions.
Many thanks. So let me wrap up and allow me also at the end to step out of my role as moderator and in my actual role. A very rich session. I think it's impossible to summarize it from the fifth revolution, a call for equity, a clear presentation, also innovation coming from the South and South-South collaboration. The fact that we are living at a turning point, both in the enormous pace of new medical content, while technology to deliver trainings is beyond what we've ever seen before. Well-being of staff, we need to put that at the center. Leadership skills, co-educate all, and then in fact, to build that alliance, and Amelia's proposal for the WHO to be a bit of a catalyst for that. Let me finish with that. Me as a director at the WHO Academy, I would want to propose that we turn a weakness into an opportunity. The weakness and this all-present lack of resources, we can turn that into an opportunity. Our intention is to create a special program for lifelong learning for nurses and midwives. But we can't do this alone. We want to be that hub that you presented, to bring all the innovation that exists to where South and South can meet, where South can meet towards the North, and the other way around. And I'm open for proposals for partners, partners that have something to bring. Please come to Amelia and me. And with that, we want to create a narrative that I hopefully can attract extra resources and donors. But a lot of the resources will have to be and will be contributed in kind by the partners. That is the idea, that is the plan, and the needs will be identified bottom up. That is our large ambition, and I hope this session can be somewhat the start of it. Thanks everybody for attention.